Hello everyone. This video is about the management of hypercalcemia, and I want to give you a quick run through of what the structure of this video, in which I will take a deeper dive into its sections. So this video, I want to define what's hypercalcemia, and then in clinical management, the first things I encourage doing is one, to assess the severity after correcting the calcium levels, to assess the severity, and based on that, choosing which route we want to take, either a severe and urgent route, or we want to do continued workup. And then for that, I will talk about that hypercalcemia I want to think about in different categories. One, parathyroid hormone mediated, and two, non-parathyroid hormone mediated. And then I'll take a deeper dive into specific findings. So let's start by defining what's hypercalcemia. It's defined as calcium levels more than 10.5 mg over dl. And then you wanna, if there are albumin levels abnormalities, you wanna correct for that. And then you can see the formula here. Corrected calcium is by serum calcium plus 0.8 multiplied by the differences between the albumin, between the normal levels and the patient levels. You can also find online calculators to do that. So what you want to do is you want to assess the levels. It can be mild, moderate, or severe. Mild is 10.5 to 12. And if single mild elevation, you can manage that outpatiently, and there's no need for referral. Moderate, similar, unless it is associated with symptoms like headaches, abdominal pain, and vomiting, and then you would manage it like severe. So severe is defined as more than 14 or 15, depending on the resource you're using. And then if associated with symptoms as well, with nausea, vomiting, confusion, altered mental status, etc., you immediately want to send the patient to the to urgent care or ED, and they will be started in isotonic saline, calcitonin, and biphosphonate. So, generally speaking, symptoms of hypercalcemia can be remembered with a famous mnemonic: stones, bones, groans, psychiatric overtones. So stones for kidney stones, bones for osteoporosis, bone pain, osteitis fibrosis cystica, groans like constipation, pancreatitis, muscle pain, peptic ulcer disease, gout, psychiatric overtones like depression, fatigue, lethargy, confusion. But now let me give you something that is key, or something that it can help you differentiate between hypercalcemia and hypocalcemia, just clinically speaking. So their association in EKG is hypercalcemia has short QT interval, while hypocalcemia has a prolonged QT interval. So how I want to give you a way to remember this and not to confuse. So I'm gonna give you a scenario, but before that, I want to make you. I want to explain what things represent. So I'm gonna use ice cream, yum, which represents calcium, and then short QT, who is a kid, a child, short QT for short QT interval. And then an adult that is long, like tall, QT, so long QT. So I'm gonna start the scenario. Imagine you're a vendor with a single ice cream cone only, and you have two customers asking for it equally, and both are persistent in asking. So you have the choice to give the ice cream cone to the short QT, the kid, or the adult, the tall QT. This is a tough situation. You only have a single ice cream cone, though. How do you make the decision? It's a tough situation. You should have prepared more for a busy day. You should have put more ice creams. But since it is what it is, there's only a single ice cream cone, and I don't know about any considerations. But if a child asks me for a sweet, for an ice cream cone, and I don't give it to them, then I am a jerk. So respectfully to your opinion, I think the ice cream cone should go to the child, to the short QT. So now, How are you gonna forget this? How are you gonna forget that the child has an ice cream cone? So ice cream, yum, is calcium, hypercalcemia, goes to the short QT, the child. Short QT for short QT interval. So hypercalcemia, short QT interval. So if you just imagine and visualize this scenario one more time, I don't think you will be able to forget it. And if you do, then I'm sorry. How are you not gonna remember that the child should get the ice cream cone? I have no comment. Anyway, so let's move on. So now in clinical management and workup, one of the first things you want to do is you want to check their medication list. You want to check if they are in lithium or thiazide lithium. It's not, you cannot take it off really, but thiazide you can. You can replace it with loop diuretics, and you want to stop for 4 to 6 weeks and see and reassess them then. But if they were not on it to start with, you will go and get a parathyroid. You will do further workup. You want to get measurements of the parathyroid hormone, 24-hour calcium excretion, and vitamin D as well. So let me tell you why. So I want you to think about hypercalcemia in terms of two categories. One, parathyroid hormone mediated. Two, non-parathyroid hormone mediated. So the parathyroid hormone mediated, think it can be high or normal. So normal is associated with something called familial hypocalciuric hypercalcemia, and high usually primary. But now the primary one is not the normal doesn't necessarily exclude the primary hyperparathyroidism. So how are you going to differentiate between familial hypercalciuric hypercalcemia and the primary one? Let me tell you how. But before, I'm gonna go talk quickly about how calcium is reabsorbed in the kidney, and I'm gonna differentiate between the two. So usually the parathyroid hormone, what it does, it goes to its receptors in the kidney and tell the kidney to reabsorb calcium. So parathyroid hormone reabsorbs calcium from the kidney, makes the kidney retain calcium. And if it was the only receptor, then increased parathyroid hormone would mean less, more kidney retention of calcium, therefore less calcium in the urine. However, it is not the only receptor. There's another receptor called calcium sensing receptor. It's present in the kidney as well. So the calcium sensing receptor, it senses increased calcium levels in primary hyperparathyroidism, and it tells the kidney, hey, we no longer need to retain the calcium because we have a lot of it. So you can let go, you can excrete it in the urine. And therefore, you have increased calcium excretion in the urine in primary hyperparathyroidism. Now, there is a disease, or there's a condition in which those calcium sensing receptors are not working well. There's a loss of function, and that is called familial hypocalciuric hypercalcemia. It is autosomal dominant and is associated with loss of function of those receptors. And what happens is that you have increased calcium levels, but they are not sensed by those receptors, and the kidney thinks that you have low calcium, although you do have high calcium, and therefore it retains more calcium and reclaims it from the urine. And that's why you have low calcium in the urine, low calcium excretion. So how are you going to remember that? I mean, you have to understand it. But besides that, I'm going to give you a mnemonic to remember this. So one is that I want you to think about a scenario where there's a skydiving contest in an ice cream factory. And there are two modes, easy versus difficult. Easy is for families, family-friendly mode. Difficult is for the primary professionals, the tough experts on this field. Skydiving, the elevation is very, very high, and therefore, they're gonna use parachutes. Parachutes is for parathyroid hormone. Make the association, they sound the same, they have the same four letters. Okay? Now, from a high elevation, you need a huge parachute. Sorry if I'm not accurate, I'm not an expert in this field. Anyway, so in a lower height, like here in a family friendly zone, you still need a parachute, but not necessarily like a huge one. So that to remind you that the familial one has normal parathyroid hormone levels, can be mildly elevated though, and the primary usually is with increased parathyroid hormone levels, but not necessarily. Anyway, how are we gonna remember the uh, calcium in the urine thing? I decided to use, or the game makers actually wanted to make the professional mode much more difficult by introduction of rain, artificial rain. But since it's an ice cream factory, the rain is made of ice cream. Yum. So that is calcium. And the rain is urine. So calcium in the urine. So think about it. Would you want to make the mode that is for professionals harder, or would you want to make the mode for family that is family friendly harder? It doesn't make sense. Why would you want to make it hard for families? You want to make it easy. So you're only gonna have the rain, the the calcium in the urine, and the primary one. And to what does this mean? That means in primary hyperparathyroidism, you have increased calcium and excretion in the urine, which is not the case for familial hypocalciuria, hypercalcemia. Now, so we walked through that, and I can walk through how we are gonna talk about primary hyperthyroidism. And primary hyperthyroidism, when that is happening, there are characteristic symptoms of the regular hypercalcemia. They would expect in other things as well: insomnia, secondary hypertension. So characteristic findings: you can have osteofibrosis cystica. You can have thinning and multi-oculated cyst in hands. You have characteristic X-ray findings that I'm not going to dive into in this video. And the etiologies could be parathyroid adenomas, hyperplasia, carcinoma. The carcinoma is associated with much, much more significant hypercalcemia generally, but it's generally all of them similar kind of mechanism, at least in terms of like effect in calcium. So the first thing you want to do first line is parathyroidectomy, and then if not, you can give Syncolit, which increases the calcium sensing receptors sensitivity to calcium, and therefore leading to decreased parathyroid hormone release. In severe hypercalcemia, you can use calcitonin. But in terms of diagnostic workup, when it's suggestive hyperparathyroidism, there are two things you want to do. One, you want to assess. There are studies to assess for risk assessment studies, and those are like DEXA scans for like bone manifestations, and then renal ultrasound or kidney, ureter, bladder to assess for stones. Then there are studies to differentiate between the types and to confirm the diagnosis, localization studies like neck ultrasound and other studies, and to differentiate between parathyroid adenoma, hyperplasia, or carcinoma. So now let's move to the etiologies where we have low parathyroid hormone. So if that is the case, if you have hypercalcemia but low parathyroid hormone, you want to do a broader workup. Things like vitamin D, parathyroid hormone-related peptides, etc. So some causes include hypercalcemia of malignancy, thyroid diuretics, lymphomas, granulomatous diseases, vitamin D intoxication, milk alkali syndrome, and multiple myeloma. So let's dive into each one quickly. So hypercalcemia of malignancy is associated with increased parathyroid hormone-related peptides, which acts like parathyroid hormone. The treatment for that, for the hypercalcemia, is calcitriol, biphosphonates, denosumab, and diet changes. Hydrochlorothiazide, the thiazide diuretics, you want to replace it with loop diuretics. Lymphoma and granulomatous diseases. So just to give you a quick glance at how it works in granulomatous diseases. In it, when you have granulomas, you have activated macrophages that can lead to increased activation of vitamin D, 1 to 5 levels, which is biologically active. Here I walk through a mechanism that you can take a look at. But generally speaking, aside from management of the underlying condition with the lymphoma, the granulomatous disease, what you want to do is you want to restrict calcium in the diet and stop vitamin D supplements. You can also give corticosteroids, which will decrease the conversion between 2,5 vitamin D to 1,2,5 vitamin D, therefore help with this, but it will take 2 to 5 days to take effect. Now, the vitamin D, exogenous vitamin D intoxication, you want to stop that exogenous vitamin D and calcium. Same with alkali syndrome. And then you can also, for that, give isotonic saline, then furosemide. Multiple myeloma is a condition that can also cause hypercalcemia with decreased parathyroid hormone. And the way it works, it's basically a plasma cell malignancy, monoclonal plasma cell proliferation, and leads to increase IL-1, IL-6, which will go to more like histiolytic lesions with hypercalcemia. What happens is that the symptoms can be remembered with an amount called CRAP. CRAP, C for hypercalcemia, R for renal, A for anemia, B for bone lesions and backbone. In it, you'll find characteristic peripheral smear findings like Rolex formation of red blood cells, and they're like a chain, like a Rolex watch. And then plasma cells can have some punctured holes as well. And then you have the monoclonal antibodies patterns that you can look at. So yeah, in terms of the Benz-Jones proteins, which are like free light chains. So this is quick. This is how you wanna work up hypercalcemia. Quick recap: one, assess if you have true hypercalcemia or not. Two, assess the severity of it and determine whether you want to manage it outpatient or you want to admit the patient. And three, you want to go through this workup to determine the cause, whether it's parathyroid hormone related, mediated or not. And then based on each one and lab findings, you want to manage them differently. Thank you so much.